I think the treatment for advanced kidney cancer has really changed over the last 5 years. Prior to 2018, we were largely using single agent VEGF inhibition to treat patients with metastatic disease. And then in 2018, we saw data emerge on IO combination therapies, improving survival for patients. And there's now a total of 4 different frontline combinations that have all demonstrated improvements in overall survival. And if I had to lump them into 2 categories, I would put them in the categories of IO, which is predominantly nivolumab plus ipilimumab, or IO VEGF, which there are 3 different IO VEGF combinations that have demonstrated improvements in overall survival. Those include pembrolizumab plus axitinib, nivolumab plus cabozantinib, and lenvatinib plus pembrolizumab. And when we think about the treatment of patients in the frontline setting, there's a lot of factors to take into account when selecting any given therapy. The IO VEGF combinations, when we look at them as a package, all the regimens, they're probably all more similar than they are dissimilar, though we like to pick them apart, but they tend to be associated with really high objective response rates, really low primary PD rates, and a good substantial PFS. When we look at the IO combination with Nivo-Ipi, the beauty of that regimen and what we've seen emerge from the data is that there does appear to be a subset of patients who derive long-term benefit from dual IO therapy. And when you look at sort of the PFS curves, there's a plateauing of the PFS curve suggesting that as we follow people over time, there's a subset of patients who don't progress and they're 5 years out from treatment initiation. And some of those people may not even still be on treatment, even though they're doing well and their cancer hasn't progressed. However, the Achilles heel of that regimen is that about 1 in 5 patients, just under 1 in 5 patients, will not respond. The primary PD rate is about 18% when we look at all comers. And so a lot of times when we're in clinic, we're asking ourselves, do I have the luxury of playing the long game and trying to think about deriving long-term benefit from dual IO therapy? Or do I have to play the short game because I want to ensure that the patient has a response? I want to ensure that they don't progress. And if they do progress, I'm worried that they may not ever see another treatment. So those are kind of the clinical conundrums that we experience. I think the other thing is there's a lot of heterogeneity in outcomes when we look at patients based on their IMDC risk factor. So across the board, these regimens have demonstrated, no doubt, a benefit for the intermediate and poor risk patients. But when we look at the favorable risk patients, it's not to say that they don't derive benefit. 1, there's not a lot of favorable risk patients, and 2, these patients do well. They go on to receive multiple other second-line agents, and it is increasingly more difficult to demonstrate a statistically significant OS benefit in this group with these regimens. It's not to say that these regimens aren't to be used in this population. I certainly use them all the time, but there's a lot of discussion to be had about which regimen to use for those favorable risk patients. But it's certainly been exciting because, we've got a lot more treatment options that are way more effective than where we were 5 years ago.